دكتور سارا موساد. نعم متهيألي هم نفس
لا حالة ثانية. هم البيدياتريك جايبين حاجتين.
اوكي.
طب مش مكتوبة يعني. طب خلاص قول.
لا
هم كاتبين على كل حاجة.
ومعاها بعد كده سؤال.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank our dear Professor Amal Bishlawi for giving us this chance. We also would like to thank our dear Professor Dr. Mona Tegi for her continuous help and support. Our patient is a male patient, 5 years old, the 6th child of a non-consanguineous marriage. At day 3 of life, he was circumcised without massive bleeds post-procedure. He presented to our hematology department at the age of 2 weeks with subconjunctival hemorrhage and purpuric eruption over his face and neck with no other bleeds from any orifices. There was a very strong family history. 3 of his siblings have a bleeding tendency. Investigations were done revealing normal CBC, normal coagulation profile, normal bleeding time, and normal liver functions. At this point, our differential diagnosis was either deficient clotting factors or platelet disorders. Platelet disorders were excluded due to the normal platelet count and normal bleeding time. The other possible differential diagnosis was deficient clotting factors, which could be either transient deficiency of the vitamin K dependent clotting factors, the so-called hemorrhagic disease of the newborn, or inherited deficiency of clotting factors, or deficiency of clotting factors in association with diseases like liver disease and DIC. In light of the investigations done, normal CBC, normal liver functions, the good general condition of the patient, besides the very strong positive family history, as 3 of his siblings had a bleeding tendency, our most likely diagnosis was inherited deficiency of clotting factors. His normal coagulation profile, PT and PTT, besides 2 of his siblings complained besides a bleeding tendency, they had delayed wound healing. So our patient and his siblings were all investigated and were diagnosed as factor 13 deficiency. He was following in our bleeders clinic. In the first 3 years of life, he had several bleeding episodes in the form of muscle hematoma, knee hem arthrosis post-trauma, and ankle hem arthrosis post-trauma, and with each episode he was admitted and received SD cryoprecipitate. At the age of 3 years, he developed high fever reaching 40s, oral ulcers which were very painful and well circumscribed, with refusal of feeding and hematemesis. Treated with local mouth care, topical antifungal, IV antipyretic, antiviral, SD cryoprecipitate replacement for 2 weeks, the patient improved and was discharged. 5 days later, the same condition recurred, but this time the oral ulcers were more severe and more painful, and there was no improvement on the same previous treatment. This is the picture of our patient. What could be our differential diagnosis at this point of care?
Our differential diagnosis were abscess ulcer, immune or inflammatory diseases like systemic lupus, Behçet syndrome, Crohn's disease, Stevens-Johnson syndrome, infectious, recurrent herpes labialis, herpetic gingivostomatitis, herpangina, necrotizing ulcerative gingivostomatitis, histoplasmosis. In light of no improvement with previous treatment and rapid recurrence, we were highly suspecting immune and inflammatory disease. Abscess ulcer.
Abscess ulcer is painful, well circumscribed and recurrent, usually heals within 2 weeks without scarring. This could be the condition in our patient. However, abscess ulcer could be the first manifesting sign of other inflammatory diseases like inflammatory bowel disease and Behçet disease.
Our second option were systemic lupus, but the ulcers are usually painless with sores in the mouth and tongue, and there's other criteria which weren't found in our patient.
Behçet disease resembles aphthous ulcer but is usually associated with other manifestations like genital ulcers and uveitis.
Stevens-Johnson syndrome, usually it's secondary to drugs or infectious, and this is not our case, and usually takes to mucous membrane and less than 10% affected body surface area. So with these possible differential diagnoses, IV methylprednisone was started at 20 milligram per kg per day for 3 days, followed by marvelous response. Steroids were then withdrawn gradually. The complaint recurred 3 times over 2 years with good response to steroids. 6 months ago, the condition recurred, but vomiting was persistent and resistant to antiemetic. Dysphagia was more to solids than to fluids, and sometimes even without meals. And this is the shape of our patient after steroid. Investigation in the light of new event. Upper endoscopy, pinpoint esophageal stricture was seen 18 centimeters from the central incisor with severely inflamed mucosa at site of stricture. Omnibac swallow, smooth long narrowing of the mid and lower dorsal esophagus with moderate dilatation of the upper cervical esophagus. Esophageal dilatation was done twice and extensive medical treatment was started in the form of high dose of omeprazole, 4 mg per kg, and ranitidine, 8 mg per kg together with IV methylprednisone. Follow-up upper endoscopy after 2 weeks revealed esophagus, severely inflamed, ulcerated, friable mucosa, multiple circumstantial ulceration with lower esophagus, large hiatus hernia with GERD grade 3. Stomach and duodenum, several diffuse gastritis with antral ulcers, severe diffuse duodenitis. Ulcers started to develop in the anterior aspect of the scrotum and penis, which healed with scarum. And this is the shape of ulcers. The diagnosis of Behçet disease was most likely our patient was diagnosed as factor 13 deficiency with Behçet disease.
The condition was very progressive during the last 6 months. Attempts to withdraw IV methylprednisone were always associated with recurrence of the ulcers. TPN was started due to failure of oral intake. The patient was ICU admitted due to severe vomiting and aspiration pneumonia. IVIG was given 2 courses at a dose of 1 mg per kg per day. Infliximab recombinant monoclonal anti-tumor necrosis factor alpha first dose was given in a trial to control the ongoing inflammatory process. There was marvelous response on infliximab. Our patient was seen smiling for the first time. The patient started to develop lower limb and upper limb hypotonia and hyporeflexia, which was more pronounced in the lower limb. Nerve conduction velocity revealed severe diffuse motor axonal polyneuropathic disease affecting the lower limbs more than the upper limbs. At this point, we were thinking, is this polyneuropathic disease related to Behçet disease? We found that central nervous system affection is common with Behçet disease. However, peripheral nervous system affection was very rare. But there are several studies and case reports which report polyneuropathy with Behçet disease, which could be immune-based. If this polyneuropathy was not related to Behçet disease, could it be a side effect of infliximab? We searched for the side effects of infliximab and it was not found among them. Could it be just a coincidence unrelated? When we searched, we found that the prolonged use of TPN could lead to polyneuropathy due to vitamin deficiency. Behçet disease is an inflammatory disease characterized by recurrent oral aphthous ulcers and numerous potential systemic manifestations. These include genital ulcers, ocular disease, skin lesions, neurologic disease, vascular disease, and arthritis. The international study group criteria for the diagnosis of Behçet disease require at least 3 episodes of oral herpetiform or aphthous ulcerations within a 12-month period, along with 2 major features, which could be recurrent painful genital ulcers that heal with scarring, eye lesions in the form of anterior uveitis, posterior uveitis, inflammatory cells in the vitreous or retinal vasculitis, skin lesions in the form of erythema nodosum, pseudofolliculitis, papulopustular lesions or acneiform nodules, or a positive pathogen skin testing. In our patient, he met the first criterion. He had 3 episodes of oral herpetiform or aphthous ulcerations within a 12-month period, but he had only one major feature, which is painful genital ulcers that healed with scarring. In this entity, it could be incomplete or partial Behçet disease. Treatment, a number of different medications can be used to treat the various symptoms of Behçet disease, but the main types of medication used can be broadly divided into corticosteroids, either topical or systemic, immunosuppressants as azathioprine, cyclosporin, methotrexate, mycophenolate mofetil, and thalidomide, biological therapies, anti-tumor necrosis factor alpha as etanercept, infliximab, and adalimumab. And thank you.
Thank you very much for showing us this very